Game over. It is game over.
Game over, cancer.
I'm Val Solomon, Director of Program Impact at Cannonball Kids Cancer Foundation.
And I'm Dana Nichols, Executive Director of CKC.
Game Over, Cancer, a podcast dedicated to exploring conversations about pediatric cancer research, solutions, and inspiring family stories.
We're a nonprofit dedicated to creating innovative treatment options for kids fighting cancer and educating for change.
By creating a space for these conversations, we empower the community to take action and provide tangible hope.
Game over, cancer. Screw you, cancer. Today's episode is all about access. We talk a lot about that in our mission, but actually today we break down even what does access mean? For us, it really started as just geographical. Can kids get on and to the clinical trials that they need to for treatment? But in today's episode, we really learn with our guests that that's maybe a first step and not the last, and there's a lot in between.
That's right. We start off talking about how access to the clinical trial is just one step, and after that, it's access to the outcomes, the desired outcomes, which, as you know from listening to our podcast, is all about survival and quality of life. So this is a great conversation.
It sure is. We talk so many people that are like living out their passion and just dedicated to what they're doing. And today's guest, Dr. Bona, she's like, you know, it's not enough. It's not enough to just cure cancer. We're going to add some other things on there. She's fighting a really good fight, and we're excited to bring more light to that and to talk about the many facets and ways we need to be supporting families in treatment.
That's right. Take a listen.
Today's guest is Dr. Kira Bona. She received her MD from the Yale University School of Medicine and her MPH from the Harvard T.H. Chan School of Public Health with a focus on clinical effectiveness. She joined the faculty at Dana-Farber and Boston Children's as a pediatric oncologist in 2012, where today she's also an associate professor of pediatrics at Harvard Medical School. The Bona Lab at Dana-Farber Cancer Institute studies outcome disparities in childhood cancer with a focus on improving childhood cancer outcomes by systematically considering social determinants of health as risk factors in the clinical trial setting and potential targets for intervention. I was so excited when I heard her speak a little bit ago, so I said, this is a convo we have to have on the podcast. Everyone, please welcome Dr. Kira Bona.
Yay.
Good morning. Thank you for joining us.
Good morning. Thank you so much for having me. I'm delighted to be here.
We are just excited whenever we get to shed light on another portion of the pediatric conversation and the pediatric, disparities, barriers, those kinds of things. And to us, there are certain things that almost are common sense. Like if you have other social risk factors or hardships, then it's harder to get treatment. But when it goes into an actual scientific field, we want to talk about that forever. So that's, I think for us, we're really excited to have that conversation. But I think we'll start at, well, how do you even come to work on that relationship between poverty and pediatric cancer?
Sure. And I'll just echo that I'm also wildly excited about this topic because I think it's one where we have a real opportunity broadly in the field of pediatric cancer to think about how we can improve outcomes for kids with cancer, which is, of course, our overarching goal.
Yeah.
So to the question of how I got to this, which is a pretty common question, the answer is pretty simple. And really the research that I do and that the folks in my lab do comes directly out of what we see in the clinic. So I have the privilege as a physician of taking care of children with leukemia and lymphoma at Dana-Farber and Boston Children's. And I can tell you that as a pediatric oncologist in clinic, we work with the most amazing families who do absolutely everything we ask of them for their kids. And still, when we are in clinic, knowing a child needs to come in for chemotherapy, we have families where we worry about whether their car is going to break down and they can get to clinic to get the chemo that their child needs that day. We worry when it's time for their child to be discharged from the hospital because we finished with the inpatient chemotherapy, whether they're going to have the electricity on at home to keep medication cold for their child. And those things, seeing day in and day out as a clinician, when I was a much younger clinician, made me wonder, does that actually matter to outcomes, even when we are providing the best standard of care that we know how to provide? And that really is the genesis of most of the research that we have done to date.
That's fascinating. And I think like even those two brief examples are like, yes, of course, that would make a difference. And of course, that's scary for the family and their medical team. And at the same time, I think seeing something and then putting it into practice, that takes a long time and takes a very specific mind. So I think, can you just start us on, well, okay, so you see this, and then how does that translate to actual clinical work?
Yeah. Another really good question, and your point is well taken. Research is a very slow endeavor. I guess maybe as a starting point, and really important to say, as normal human beings in day-to-day life, we all know the idea that if I don't know if either one of you have children, I have 2 kids. When I think about the things I need to do on a day-to-day basis for my kids in terms of feeding them breakfast and getting them to school, I recognize regularly that if I didn't have enough food at home or I didn't have some way to safely get them to activities, that would be a problem for me. And that in the context of what if they were sick as opposed to healthy, would that also be a problem? And the common sense answer is yes.
Yeah.
And going back to how do you get into the research, I can tell you that when I was a fellow, so when I was in training to become an oncologist, we as a field in pediatric oncology didn't actually believe that those exposures, what we call social determinants of health, so those are the situations in which we live and work and grow and play, like having enough food on the table or having a car to get to work or the hospital, we didn't believe that those mattered for kids' outcomes. And that was not, I will be clear, because we're evil in pediatric oncology. Even though there'd been about 50 years of really beautiful research in general pediatrics, so among healthy kids in the United States, showing that living in poverty, for example, is bad for kids' health, makes kids more likely to be hospitalized or have infectious disease or to die as compared to other kids. We thought in childhood cancer that we actually were able to adjust away for that because of how we deliver cancer care. And that, is it okay for me to talk a little bit about that?
Yeah. Yes, please.
And that how is actually very different than in almost every other field of medicine. And it comes down to a numbers game. So as you absolutely know, childhood cancer is thankfully very rare. So what do I mean when I say that? There's about 15,000 children diagnosed with cancer in North America annually. That's a pretty small number, right, as compared to 1.5 million adults diagnosed with cancer. From a practical standpoint, that means in pediatric oncology that we recognized as a field decades ago that one individual hospital was never going to be able to do a study, a clinical trial to figure out, does treatment A work better than treatment B on their own? And that was simply because one hospital would never see enough children with cancer to answer that question. And so the field of pediatric oncology decades ago banded together to create what we call these big cooperative groups, which are basically an agreement across institutions across all of North America and now the world, where, for example, 190 hospitals will say, we are all going to enroll children on the same clinical trial so we can answer the question, does treatment A work better than treatment B? And that is an approach to care that's really different than in any other field of medicine. And it means from a very practical standpoint that in childhood cancer, most kids with a new diagnosis of cancer will be treated on a clinical trial if one is available for them. That's really different than in the adult oncology world. And I'm coming back to my point here. Because of that highly standardized care, we thought in childhood cancer that then there wouldn't be disparities in outcome. Because if we know that kids are being treated at big hospitals, big academic medical centers, and they're being enrolled on clinical trials, getting the highest standard of care, access to the newest therapies that you could possibly give them, that should adjust for disparities that are seen in other settings like primary care pediatrics. And that, I'll just say, led to what I now see as a blind spot for us as a field, in that since we thought that was the case, we didn't actually ask the questions in our clinical trials about whether that was true or not. We just assumed it to be so.
Right. And I think that that's a wonderful illustration of what Dana was talking about, where you think something might be common sense or something that's like generally understood, when you don't have food or when it's hard to meet those basic needs, you can't meet any higher level needs past that. Seems like common sense until we get into the piece where we're thinking about all the other things that we're doing for the children. It makes total sense that there would be that gap gap, I think. And yet, what do we do about it? So now we know that there is potentially this gap. And your lab and your research is focused on what can we do about it. So can you tell our listeners a little bit more about the types of research that you and your other colleagues are doing to help address this gap in care?
Happily. So we started with a very basic question, which I told you that historically we hadn't thought this mattered. So the first question was, does it actually matter? And does it matter in the setting of how we actually deliver care to kids with cancer? And so really for us, that's in the clinical trial setting. So the original research that we did was in many ways stupid simple. We went back and we took data from clinical trials that had been run across the United States that had already been published, where we already knew the outcome of the clinical trial, like what was the best treatment. And we reanalyzed those clinical trial data, asking the question, did it matter, for example, if you were exposed to poverty while enrolled and getting treated on that trial? And I will give you a little kind of research-heavy tidbit there, which is that I already told you we hadn't thought it mattered, so we didn't collect data from parents on those trials. But what we did have access to was a child's insurance at the time that they were enrolled in a trial, because that's information that hospitals and trials collect. And you can actually use that as a pretty good measure of whether a child lives in a low-income household, simply because Medicaid insurance in the United States is most commonly used for children who live in low-income households. Mm-hmm. So when we did that and we went back and reanalyzed trial data, the punchline of those trials was pretty surprising, honestly, even to me, who was asking one of those questions. And so as one very concrete example, we looked at clinical trial data for children with a diagnosis of high-risk neuroblastoma. Neuroblastoma is the most common solid tumor in children. And we looked at a trial where those kids were treated with a really cutting-edge novel therapy called Dana-Farber. And it turned out in those trials that children who had Medicaid-only insurance, so lived in low-income households, were almost twice as likely to have their cancer relapse and almost twice as likely to die, despite being enrolled on a clinical trial and treated at big academic medical centers like my own. And that result was pretty striking for two reasons. The first is, maybe it did matter. The things that we see in clinic and we think about on a daily basis, maybe enrolling in trials is not good enough. And the second, I think, is the question we're really asking, which is, well, what do you do about that if, in fact, that's true? Because I'll tell you, as a researcher, when I first presented data from that analysis of the trial to my colleagues, the response was really twofold. The first was, wow, that's a really striking difference in outcome. And the second was the slightly more tongue-in-cheek or depressing response, which was, what are you going to do about it? Cure poverty? Which is kind of that response that all of us have, because the concept of addressing social determinants of health, of addressing the exposures that a child has outside of the hospital, independent of their cancer diagnosis, feels pretty overwhelming and paralyzing to us as physicians, I think. Mm-hmm. It feels as though it's something kind of beyond the scope of what we can do. And I think that has been a non-starter for us in the field for a while, thinking about disparities research. And I guess just to put in a little plug before I'll stop talking so you can ask me another question, that was the response. And in some ways, one could say, well, I don't know, I can't cure poverty. But the reality is, not to sound too insane, I'm a pediatric oncologist. I have the incredible privilege of thinking that I can help take care of kids and cure cancer. Mm-hmm. And if we can cure cancer in kids, then I really don't think it's even vaguely silly to think that we could figure out how to put food on the table and potentially cure poverty-associated disparities in relapse and survival. And so I think the answer to that is, yeah, actually, if we can drug molecular targets in childhood cancer, I think we can probably figure out how to drug poverty. And so that was kind of where we started with the research, and now we've gone in fun new directions, but I'll pause there before.
You know what? I'm sorry. I'm just like, you know what really is coming to mind here is what you said about the reaction you got from colleagues about, well, what do we do to help cure poverty is kind of what we talk about when we're talking to any of our listeners, any of our audience.
Yes.
When we say, oh, well, we're going to fund clinical research for kids. And they're like, you're going to cure cancer. It's the same big, overwhelming problem that feels really hard. And you can get stuck thinking about doing the big thing instead of just taking one or two steps to get you a little bit farther so that you're not ignoring it. Right.
Yeah, absolutely.
And, when you were talking about that, I was like, oh my God, I've had that conversation a million times with people about cancer.
Right. And I think to your point of like the non-starter is like, so our answer is that, okay, so what's the first step? What's the one thing that I'm going to do next to get going? Because now we know this. We can't unsee it. The curtain's been, pulled back. So it's not enough to just do the one thing that I'm already doing. I'm in this lane. I've heard this problem. I need to go forward. It's, and like you say, those are striking statistics and unseeable in that sense.
And I think it's really interesting, and I just admire you and your team and anybody who's looking in this in this area of research, because I think it takes a lot of courage in some ways to pull that curtain back, right? To say to your colleagues, hey, we could be doing better, and look at where we haven't really addressed this issue that is affecting outcomes. Because like Dana said, we've met a lot of pediatric oncologists, and they are people who are going to be like, oh, okay, well, now that we know, let's do something about it, right? These researchers are not happy with the current state of treatments for kids. That's why they do what they do. So, I think it's sometimes problematic to ask those questions. And it's very courageous when it happens.
Yeah. So here's my next question, which of course needs a tiny bit of preamble. So you are saying that the intervention needs to be calculated into actual health outcomes, into medical care, right? So I think I'd love to talk a little bit about the difference there between putting it into actual like practice of care versus what we see a lot, which is we have social services, we have social workers, we have child life. We have a lot of wraparound services that aim to, come alongside these issues. So you're taking it one step further than that. And I wondered if we can talk about why that has to happen that way.
I love that question.
Okay, thank you.
It's a really important question. Let me answer that because I think that then plays into that big question coming down to researchers and oncologists, which is like, what do you do next, right? It's not good enough to know. The question is, how do we take that information to then improve things for the kids who we are lucky enough to get to take care of? So to that question, yes, we are so incredibly lucky in pediatric oncology in particular, in that we just have exceptional, I guess I would say, holistic care, right? We have a cadre across the country of social workers, resource specialists, psychologists who partner with the nurses, the physicians, the physical therapists, taking care of our kids when they have a diagnosis of cancer. And they are amazing. And the very quick answer is what they do is so amazing, and we could not do without it. And the data tell us it is not good enough.
Okay.
And what do I mean when I say that? Those clinical trial results that I just told you, where we looked and we saw that even in the context of a clinical trial, children who were proxied as being exposed to low income were more likely to relapse and die. That was in the context of receiving care at big academic medical centers,
right,
with social workers and psychologists and resource specialists, getting all of the supports that we can throw at them. And that's still the outcome we saw. And that to me says what we're doing is amazing, but it's not amazing enough. And we need to figure out what are we missing and how do we then systematically add an added layer of support on top of the beautiful system that already exists. And I want to be very clear, this is not a critique of the amazing work that our social workers or resource specialists do. It's the same acknowledgement when we have a drug that is really good at putting a cancer into remission. but it doesn't cure all of the kids, we say that's great, but it's not good enough. We need another drug. We need to add on to what we have already.
So we're really not even talking about a replacement. We're saying this is, and you use the word layering, which I think is so beautiful, of like, we're saying there's this beautiful holistic care. This is the next step of what needs to be happening as far as to getting them further into a survival or a thriving mode during and after treatment. Okay, cool.
And in my mind, I would think about that like we think about a lot of other supportive care, right? For example, no one thinks it's crazy when we say, oh, kids are still having nausea and vomiting during their chemotherapy. We should figure out, are there better medicines to prevent nausea and vomiting? Doesn't mean we eliminate what we have already. It says, oh, we can do a little bit better than that.
Mm-hmm. Exactly. Yeah.
So then I think the next question is, okay, so what do we do? We've teed this up for like, the whole time of we've layered. We know it's not good enough. Okay, so what do we do now? Tell us the secret.
Sure. So the secret to that is multi-component. And the first secret was that we as researchers needed to figure out a framework that would be obvious to our colleagues, that would be one that we could get oncologists and funders to buy into so that we could actually move forward with kind of a good strategy for studying this problem, designing interventions to address it, and then testing if those work. And so that framework, again, most of the research that I and my group do is stupid simple, was not very complex. And that was to take the analogy I gave you at the beginning and say, okay, poverty may feel overwhelming, but if I told you that we had just identified a new genetic mutation inside a tumor that was associated with relapse of that tumor, nobody would feel overwhelmed by that in pediatric oncology. Folks would say, oh, that's great. We know exactly what to do. And we have this recipe in pediatric oncology that we do when we find a new mutation. And we do three things. The first is in the next clinical trial, we collect data on that mutation and we make sure we got it right. We make sure that, yes, that's actually associated with relapse and survival. The second, at the same time, we ask our colleagues in the labs to figure out the mechanisms that are driving that risk of relapse associated with the mutation. And then the third is that we drug that mutation. And the secret there is we don't wait till we've figured out the mechanism that is making that mutation cause cancer cells to be resistant to our treatment. We drug it right now. We intensify the chemotherapy that we are giving you while we are figuring out that mechanism, with the idea being, if we know that a child is at higher risk of relapse, we don't wait till we know the full pathway. We try and do something about it while we're figuring out that pathway. So that's the recipe we use all the time. And we said, all right, that recipe works for mutations. Let's just take that and apply it to social drivers of health. For me, poverty is the one that I'm most interested in, but you could apply it to anything. And so we're doing exactly that for the framework. We are, number one, collecting data from families in clinical trials on what we call modifiable poverty exposures. So if you're going to try and drug a poverty exposure, that means that you actually need a measure, something that you can intervene on. And so when I say that, I told you already in the clinical trials we had to use a proxy measure. We used Medicaid health insurance to identify kids who lived in a low-income household. I can tell you, those children did not have their cancer relapse because they're insured by Medicaid, right? That is a marker for something else going on at home. I also can't design an intervention to target Medicaid. So the question is, what are the things that a parent could tell us that we actually could intervene on? And so, again, very stupid, simple research, but part number one of that recipe is collecting data. And so the first thing we did was design studies where we collaborated with our colleagues who run clinical drug trials across all of North America. And we embedded surveys inside those clinical trials so that when parents chose to enroll their child on a clinical drug trial, they had an option of saying, yes, I will answer a survey that tells the researchers about the household where that child is living, so they can use those data to then study what exactly is associated with outcomes in the trial. Mm-hmm. And so we did that in the context of the Children's Oncology Group, and we collected data from parents on, for example, household income, food insecurity, housing insecurity, utility insecurity. Can I keep the heat or electricity on? And that was step number one to find the scope of the problem, which I will tell you, and then I'll stop talking.
Don't ever stop talking.
and part of that research, there was a research question of, can you do that? The answer to that is yes, we can do that. And I can tell you data on that if you want to hear it, but I think that's not the exciting part. The more important part, I think, was figuring out, all right, we've shown that poverty exposure is associated with outcome in trials, but does that actually matter? Is this something we should care about as a field? Does it affect enough children that it's a problem? And the punchline answer to that is really straightforward. Yeah, it matters a lot. 1 in 3 children at the time of their cancer diagnosis and enrollment on a clinical trial is living in a household that is exposed to poverty. And that's, you can use 2 different measures. If you want to use income, so the federal government definition of a low-income household, that's 1 in 3 kids at the time of their cancer diagnosis. If you want to use very concrete exposures, like being worried about putting food on the table, being worried about being evicted from your apartment, being worried about keeping the heat or electricity on, that's the same number. 1 in 3 kids at the time of their cancer diagnosis, which means that if we can figure out how to tackle this problem, we have the opportunity to improve outcomes for 1 in 3 kids with cancer. That is way more than I'm an oncologist. I get excited about mutations and like new targeted drugs all the time, but that is a far bigger population than we ever talk about with our mutation.
Yeah.
So that was step number 1, collecting the data, scope of the problem.
Mm-hmm. Well, tell us about step number 2.
Yeah.
All right, then I'm just
firing on all cylinders here.
This topic, in case it's not clear, gets me a little excited because it's really fun research and it feels like hopefully we're going to move the needle for some of the kids we get to take care of. So that was the first part. Can we collect the data? Can we identify the scope of the problem? The second part was, can we start to figure out the mechanisms, right? Can we figure out the why of why, even if we treat you on a clinical trial at big academic medical centers, your cancer outcomes are still not as good as if you live in a wealthier household. Mm-hmm. And I'm going to tell you right now, we haven't cracked this nut yet. We don't know the answer to why, but we're working very hard on it. And we're taking 2 major approaches. One is to study what we call socio-behavioral mechanisms. So those are questions about, is this because we have more chemotherapy delays during treatment, or we have to reduce your chemotherapy more often for reasons such as toxicity or your ability to get to the hospital? Mm-hmm. We're using data from clinical trials to start answering those questions. So far, the answers seem to be no. So far, we have not been able to identify differences in how often we're delaying your chemotherapy, which is interesting because I'll be honest, I thought we were going to see that when we started looking, and we haven't yet. We are asking questions about, is it harder to be what we call adherent? Is it harder to stick with a really complicated schedule of taking by mouth oral chemotherapy medicines at home for months and years? We don't have the answers to those questions yet. We just finished collecting data that are going to let us answer that question pretty soon. And then the separate focus that we're looking at is very different, not about those socio-behavioral mechanisms, but we're interested in the question of whether a child who develops cancer while living in a household that is exposed to the stresses of, for example, food insecurity, whether their cancer cells might actually be more resistant to chemotherapy or to immunotherapy. And that may sound a little far-fetched, although there's a good scientific basis behind that hypothesis.
Say not to me, but
that's an area of investigation that I'm somebody who works with data and surveys. I don't work with pipettes or biospecimen samples. So I collaborate with colleagues across the country to start asking those questions. And we're in the middle of a number of investigations asking that in leukemia, which is the most common hematologic malignancy in kids, asking that question in neuroblastoma, which is the most common solid tumor in kids. And I'm hopeful that as we get answers from those studies right now, that will help us to decide whether we need to change some chemotherapy drugs that we're giving, for example, to put cancer into remission or keep it there. Mm-hmm. So that's step number 2, the why. Should I keep going?
Yeah.
All right.
Tell us
and
3.
then step number 3 is that concept of drugging it, right? Okay, we're not going to wait till we understand the why. We're just going to try and intervene. And that honestly, I will say from a research perspective is the most exciting for me right now. And that's because I'm an oncologist and we're very impatient and we're also stupid simple and we like to just do things. And so we are working on developing what we call, we affectionately call them health equity interventions. These are supportive care interventions that are targeting different exposures that children might have. So for example, food insecurity, not being worried about having enough food on the table, or low income. And we're developing interventions that are designed to actually reduce those exposures, to reduce food insecurity or to make you not be living in a low-income household, with the idea being that maybe if we can reduce the exposures, then we could have the potential to actually improve outcomes. And so thus far, our group has developed and piloted 4 different interventions that are in various stages of testing. I can talk ad nauseum about any of them that you want to hear about. And we're moving now into the first ones where we're actually going to be evaluating what we call the efficacy, whether those interventions are actually going to improve the outcome.
Mm-hmm. Well, I feel more hopeful than I did at the beginning of this conversation.
Okay.
I'm really excited that this kind of work is happening because if something's happening that's impacting the outcomes for a third of the kids who are fighting cancer, I'm just so glad someone is looking at it, right?
Yeah, that's such a large, and like you say, the statistics just, I think, probably motivate you so much in the sense that, like, I think this is a thing. Whoa, this is a thing for real. Really shows you how much progress you can make, like you say. I also love, and this is one of the things I love about oncologists in the pediatric cancer world, is like, yeah, we're trying to figure out the science and we're actively working with families that are in treatment right now to be helping them. We can't just wait to understand and solve the problem in a real like lab, data way. There are kids now that are fighting cancer that need our help. And I always think that's one of the most beautiful things about the research world, is that because so many of you see patients, you understand that these are real people and it isn't just the hypothetical, it's the literal, how am I helping this child I've met? And that's really, really cool.
Yeah, absolutely.
I'll tell you, I worry every day that we're not doing this work fast enough, and that if we just had more hours in the day to accomplish this research more quickly, that we get there when we need to, which is now, because to your point, in clinic and in the hospital, this is a reality for families right now whose child is diagnosed with cancer. And the idea that your child being diagnosed with a life-threatening illness may not be the hardest thing going on in your life, that you also might be worried about feeding them or feeding their brothers and sisters or getting them to the hospital for their chemotherapy, in some way, not only does it hurt my heart as a human, but as an oncologist, just boggles my mind that I have not yet successfully come up with the systematic intervention that we can roll out nationally across all of our centers, knowing that it's actually going to kind of level the playing field and make sure that those kids are just as able to benefit from the best chemotherapy we have to offer, which is, of course, the goal. The goal is to improve outcomes for the kids we take care of.
Yeah. Absolutely. Ours as well. And I think we feel that every day. We want to be able to celebrate the work that's happening or the funds we're raising to give out for research. And I think it's really hard not to get bogged down in this isn't enough. Like this is only going X amount. And we know that it's such a long slog in what kids need right now.
Yeah.
I wondered, you have all these things in place, you're working on it, and we've used the words common sense a few times. We've said this all makes sense whether we see it statistically or not, but I would assume you've received some pushback on your work. And I wondered if you did, and if so, what that looks like.
It's a great question. I'm going to give 2 pretty different answers.
Okay.
The first is, I'm middle-aged, mid-career now, so I've been doing this for a while, and I've been doing this since before it was cool. For me, when I was an early career investigator studying this question of poverty and did it matter, I think the audience where pushback mattered the most originally was honestly my colleagues. So pediatric oncologists across the country, understanding whether we could generate robust enough data so that we could all be on the same page and say, yep, this is actually a problem. Yes, this matters. Yes, somebody should do something about it. And so I guess just to say 15 years ago, pushback might be the wrong word, but the sense in the field was really that this was not a problem.
Yeah.
And so there was really an initial probably 5 to 10 years of needing to spend time generating the data to say it's a real problem. It's a problem across diseases. I told you the data in neuroblastoma, but that's just one disease. And as oncologists, we always worry, okay, maybe that's true there, but not here.
Yeah.
And so we took a decade to say, this is a problem in neuroblastoma. This is a problem in leukemia. This is a problem in Ewing sarcoma. We took a decade to identify the scope of the problem. And so pushback, again, may be a little bit strong, but I do think now that the field of pediatric oncology recognizes that we have data saying that this is truly a problem for the patients who we are taking care of, and that we have to figure out how to solve this problem if our goal is to cure every child of cancer, which I think is the goal of most pediatric oncologists in the world. So that was kind of the first battle, and I'm just delighted that we're at a point now that feels very different, where there's real commitment nationally by the Children's Oncology Group, by investigators and clinicians across the country who want to collect data on this and contribute to the research in terms of how we make it better. I think the second place, so that's kind of the field and colleagues and a little bit of changing hearts and minds. The second place is more in the bureaucratic infrastructure and funding, and that has been a little bit more of a challenge recently. Mm-hmm. And so I guess as one very concrete example, the National Cancer Institute is an amazing organization in the NIH that provides a bulk of funding to cancer research across the United States, including to pediatric cancer research. And the NCI supports the Children's Oncology Group, which is that big clinical trials group that runs trials across all of North America. And the NCI has been pretty clear that the conduct of health equity research falls outside their scope and purview. And so they have not been excited about us doing this research in the context of the Children's Oncology Group. And that for us definitely has been a challenge, because that's where we do most of our research in clinical trials. And I guess I'll put that out there as sharing a barrier in that, we've come up with a solution for that. That is what you do in medicine when there's a problem. You come up with a workaround solution. And so the really great news is that we took that as kind of a field, and we established a new consortium called the IGNITE Consortium. And that is a group of investigators from 12 of the big cancer centers across the United States, on the West Coast, East Coast, North, South, Midwest. And we have banded together to say that we are going to run health equity research through this consortium so that we can test interventions and figure out whether they are feasible to do, whether we can systematically evaluate them across centers. And so that's been a real win.
Yeah.
I can pause.
Well, I think it's a win, but it's adding additional work that was already in progress. It's slowing down to make sure that really important work continues to happen instead of being able to just move forward. So I think it's a beautiful bright side you're giving us, but it's a whole additional consortium of something that a consortium already existed wholly to take care of children. So it's great. I'm just giving my opinion. Not that you asked.
Your opinion is valid. Yeah. I will validate that. And I will say, to your point, it then comes with not to go into the funding space, but research.
How can we not, though?
It takes funding to support the research staff who are enrolling patients, giving surveys, to support the cost of the interventions, just like the cost of a drug. All of that takes funding. And when you have a new consortium, you have to fund the infrastructure for that consortium, the infrastructure to run the trials. And so that definitely, without question, has been a challenge for us, particularly over the last few years.
Yeah. Yeah.
It's like a duplication of something that was effectively working before, unfortunately.
Right. And I think we talk a lot about, even from for us, it always comes back to our grants process of, if there are all these family foundations doing the work, that's great. But if we're asking every researcher to serve on a scientific advisory board, to put in an application, anything that takes time away from either bedside or in a lab that is trying to solve this problem feels it's a hard pill. It's unnecessary. It's a hard pill to swallow, to make sure that progress happens on a really, really long game we're all playing. So, yeah. I think that as much as we could talk for 10 more hours, I would love to, if at all possible, wrap up on a hopeful note. I wondered what you're excited about for the future. I'm already saying, can you come back and we talk again? Because I think there's just scratching the surface of so many exciting conversations conversations, but would love to hear just what you're excited about that's happening and just add a little bit of a hopeful note to a really, really important big job you're doing.
Oh, well, I think there's an endless assortment of reasons for hope, and there's a lot of stuff I'm excited about. But I guess making that quick and pithy, what I would say is I'm excited about the fact that we now have identified a problem that 10 years ago we did not know existed. Mm-hmm. We've identified that the scope of that problem is big enough that it impacts 1 in 3 kids with cancer, which is maybe one of the biggest opportunities in pediatric cancer to improve outcomes that we've seen in decades. My colleagues might strangle me for that comment, but I'll stand by it. I think it's true. I think what I'm most excited about is that we now have the first health equity intervention that is specifically targeting low income as a risk factor for outcome. We have the first health equity intervention that is currently being run as a randomized phase 2 clinical trial to see if we actually have a signal of impact on outcome. And that is a pretty exciting breakthrough. That is a first in field accomplishment for us. And I'll say, not to put a downer on this, it's really all about the hope. It's probably going to fail, right? We know most drugs that we test fail. They are not successful. The first one that comes out of the drug company, the second one, the third one, honestly, the 10th one. That's not how it works. But that's okay, because even if this one intervention that's now in this randomized phase 2 trial at 9 centers across the United States, even if it's not successful in showing us that it's effective, we now have a template for moving forward. We have a consortium in which to do that, and we can replicate this over and over again. And we have a cadre of incredibly fierce, dedicated, brilliant investigators across the country who are committed to making the science happen. And you really don't need anything more than that to have a lot of hope for the future.
Absolutely. And I think too, even saying, 10 years ago, this is a problem that doesn't exist visually. No one's acknowledged this. Here we are today. And I think that's why research is so important. That's certainly why we're here as a foundation to raise the flag, raise the alarm, raise the funds for research, because whatever's happening today could be really, really different in scope in 10 years if someone starts working on it. So I think that's hopeful. I am so grateful that you came on this podcast today, took your time to do this with us. Thank you so much. It means a lot to us. Overall, the reason CKC invests in innovative research is to make life easier for our kids and families, give them treatment options, give them a chance at survival, and to be able to thrive. If you, as a listener, want to support the research that makes this happen, you can make a gift on our website, cannonballkidscancer.org.
That's right. We want to thank you for listening to our podcast, Game Over Cancer, and particularly this episode with Dr. Bona. This has been incredible, eye-opening, I think, conversation. But it doesn't have to stop now. We'd love for you to like and share the podcast and this episode, comment on our reels and the full episode, and the conversation can continue.
Absolutely. Thanks for tuning in. We appreciate you joining our commitment to be part of our fight. Until next time, I'm Dana Nichols.
I'm Val Solomon.
And we will see you later.
Join us as we transform fear into courage and turn adversity into opportunities for change.
If you want to be involved in the conversations that create change in the world of pediatric cancer, take a moment, share, like, and subscribe.